Joining us now on the show, we welcome from Henry Ford Jackson Hospital, Medical Director, Primary Health, Dr. David Coldy. From the ER Emergency Physician, Dr. Ellen Lazara. And from Home of New Vision, Peer Coordinator and Recovery Coach, Brooke Cross. Welcome to the show.
Thank you.
So during the pandemic, we didn't hear a lot about opioid use and abuse, but I understand it got worse during the pandemic. Is that right?
Yeah, I think when people are holed up at home and they don't have access to their counselors, to their therapists, to the support systems that like AA or Narcotics Anonymous meetings, they definitely can lapse in their treatment and lapse in their sobriety. So yeah, we saw that with alcohol abuse, also opioid abuse too.
And there's this disorder called opioid use disorder, and David, that's something I have never heard of before. What is it?
So opioid use disorder is a condition where patients or individuals use opiates in an inappropriate way. So you could have somebody that actually gets prescription opiates, but they use them incorrectly, and their behaviors start to kind of slide into seeking, using more than they should, buying them off the street, etc. So that's when we know people are in trouble.
And Brooke, you actually are in recovery yourself.
Yes, sir.
From opioid use?
Opioid use disorder.
How did you get your first opioid pill?
From a doctor. I had a surgery, a C-section, and I was prescribed narcotics, and I continued to seek them. I went to different doctors to try to get more until I was no longer able to get them, and then I was physically addicted to opioids. So I turned to street drugs. I turned to heroin for about 8 years, and then I caught wind of a medical assisted treatment where it could help me through the withdrawal to be able to transition my life. So I accepted the treatment and was able to recover my life with using the medical assisted treatment.
And the way you started, that's the exact same way everyone starts. That's a prescription. They had orthopedic surgery, they had a C-section, they had a car crash.
There's a lot of avenues into addiction, and I think whether your addiction's food or cigarettes or alcohol or opioids, the physiology is all very similar. It's all, some are socially acceptable and some are not, but that is a very common story that I have heard in the ED and with the patients we see. And as a resident, there was this large amount of prescribing that occurred in the 2000s, 2010. I became a resident in 2010, 2014, and then we started to deal with, as the prescribing was going up, we would see the overdoses and the excessive use come into play, and so then the medical community started to pay attention to that, and everybody started to turn off the faucet. But the problem with just turning off the faucet to opioids is just what Brooke described, is that you'll seek and find other ways to fill those receptors in your head, because people's chemistry in their brain changes. Over time, you develop a dependence and you develop a tolerance to opioids, so you need more and more, which happens with a lot of different chemicals that people end up abusing. It's part of the physiology of addiction. And so these new treatments that we're able to offer started, I don't know, they've been researching different kinds of medications, but for decades, but one that's become very successful is something called buprenorphine or Suboxone. And so although Brooke didn't use Suboxone or buprenorphine, she used a similar type medication. And buprenorphine, and Dr. Coldy can help me with this too. So buprenorphine is a partial agonist, and agonist means it fits well in the receptor, it stimulates it, but it's also a partial antagonist, meaning it fits there so well that and binds so strongly to the opioid receptors in your brain that it won't let things like heroin or fentanyl or Dilaudid or Percocets or whatever you're taking bind. So it protects people while satisfying the physiological craving and need. Treatments don't escalate over time. You don't have to be on, 8, 16, 24, 32, 64. It doesn't go up and up and up like people who take who have opioid use disorder and take Percocets. Over time, you take 2 pills a day, then you're taking 10 pills a day, you know, in 2-3 years.
Yeah.
So this is prescribed at the same time that an opioid is prescribed?
No. No. I mean, ideally, you're getting somebody off of the opiate and getting them onto this. There is some new thought that we do microdosing, where we're giving at the same time somebody's on an opiate very small doses of this. The problem is if I give somebody a big dose of Suboxone or buprenorphine while they're on their opiate, it has a stronger magnetic effect, as he just said, to that receptor. It will kick off the other opiate, and somebody will then be in acute withdrawal, and they'll be sick. And I've seen it happen in my office. Literally, people will say, "Oh, doc, I didn't take my opiate for 24 hours." And I said, "Okay, take this," and then they get sick.
Oh, wow. So, Brooke, at what point, when you were taking the opioids, you didn't have any pain from the surgery, but you still wanted, the pain was gone. Mm-hmm. So is there a point where the pain, you don't need the pain pill anymore, you felt you needed the pill?
Yeah.
Even though the
yeah,
pain was
I liked
gone?
how it made me feel and stuff, so I wasn't being offered them. I went to seek them out.
Wow.
To get
Very,
them.
very powerful draw. So
Yeah.
how long does it take before someone's got the hooks in them?
So through studies that have been done through the emergency department there, and I don't have the exact numbers, but there's a very small percentage of people who get a small prescription of opioids from, say, the emergency department and will still be taking them in like 3 months' time, and not necessarily related to their broken bone or whatever. Like, some people just have addictive personalities, and if you could put video games in front of them or McDonald's or whatever, it's still they're gonna have some addictive behaviors. But by and large, you know, physicians as prescribers, whether it be surgeons or family physicians or ER doctors, we have educated ourselves on the dangers of opioid use, and believe it or not, you don't really get a whole lot of classes in medical school about how to manage pain, either acute or chronic. And so there was a study that came out of University of Michigan like a decade ago where they said, we're going to standardize how many pills somebody gets for like a C-section or a gallbladder removal, because they were all over the place. And so were, I imagine, many surgeons. You know, you could get some people who had a knee replacement and they'd get 60 Percocet for like the pain that they have usually lasts for like a week after the surgery, or maybe less than that. So somebody doesn't need all those pills laying around. And so they decided in the study, you know, 8 pills for a gallbladder removal, you know, 10 pills for a C-section, something like that. And so to standardize it in such a way with some research to, again, turn off the faucet. And anyway, but there are a small percentage of people that can get addicted from a very small prescription. But with that said, I wouldn't fear, you know, if you came to the ER and you broke your leg, something horrible, I wouldn't fear giving you, you know, 10 pills of Norco if you needed it. But by and large, Tylenol and Motrin do a really good job if you're taking them the proper way.
All right, you brought some slides.
Yeah.
You always bring slides.
Every day's a school day,
Yeah.
Bart.
All right, let's take a look.
So this was, okay. Oh yeah, I think David can talk about this one.
Yeah, so this is a really interesting slide. It shows the brain, an MRI, and it shows on the side there the different milligrams of buprenorphine that this person is on, and the receptors, when they are saturated, you can see the brain is all blue. Where there's some ability there, the brain is feeling the need or want for an opiate, it's in the green. And so it doesn't take a lot to saturate those mu receptors for the opiate. And so I often will have people anywhere from 8 to 16, occasionally 24 milligrams, and they have no craving for other opiates.
And the goal of this medication is not to, you know, some critics of it would say, well, you're just trading one pill for another. In some sense, yes, but studies have shown that people who are on things like Suboxone and buprenorphine are much more likely to stay in treatment, to have less health effects like getting hepatitis C or other IV related pathologies. And it also protects people from overdose because there's a ceiling effect to the respiratory depression that we get with opioids. So if somebody takes too much of it, it's almost, you can overdose on anything, but this is extraordinarily hard to overdose on. Whereas if you took a handful of Norco, you could definitely overdose on that very easily.
So the amount of Norco, let's take your example, Brooke. So you end up running out of the prescription, you still have the craving for it. Is there a safe or maintenance mode for opioids, or is it once you're taking opioids, you just keep wanting more and more? Is that what happens?
You need more to get the same effect.
Okay.
I feel like, yeah.
So you can't, like a heart or a statin or a blood pressure, it's not a pill that you want to have someone on for a long time.
No, not unless you have like a terminal diagnosis like cancer. I mean, there are select populations of people that just need opioids for pain control. If somebody has bone cancer, it's extraordinarily painful. But by and large, these pills, and there's lots of documentaries out now, and there's shows on Hulu and everything talking about how big pharma, the medical industry itself is also partly to blame, I think, as well, because they came with this panacea of 2 pills a day and your chronic pain will be controlled. And medications are not the answer for everything, for sure.
Yeah. Some people will, in Brooke's case, I think, you said the pain kind of wasn't the issue. It was you were taking them to feel normal, because people do develop this tolerance to them. And so they need that higher dose. If they don't get it, they get sick. Their brain craves more, and if they don't get it, they start to feel ill. And so they take it really to feel normal. And so I think people would be surprised the number of professional, functional addicts that are out there.
Sure.
There's this stigma that people that are addicted to pain medications are homeless or whatever, and that's so not the case. I have a number of professional people that have jobs and families and are functioning that are on opiates.
Wow. Can you die from opioid use disorder?
From opioid use disorder?
Opioid
Absolutely.
use disorder? Yeah.
Because you're going to take too much of the opiate, and it's going to decrease your breathing, and you suffocate, essentially.
Yeah, and that's actually the #1 cause of mortality for people in the United States between the ages of 15 and 45. Above,
really?
Yeah, above car accidents. Yeah, it's much more dangerous. And so you can see, this is a great slide because it shows and speaks to what we're trying to do with our collaborative here, and between our primary care doctors in the community, our emergency department, and then outreach organizations like Home and New Vision, we want to create a non-judgmental, safe place for people to get treatment. And so if somebody comes in, say they took too much of the opioid, they had an overdose in the field or at home, and then they got naloxone or got reversed, they got put into withdrawal immediately, they feel terrible. They used to come to the emergency department, we would give them medications just to try and treat the symptoms, but it was very ineffective. We didn't have much in the way of making that go away. And you can see that slide on the right there with the big bar graph. The risk of overdose is highest right after somebody is discharged from the ER.
Wow.
Within days. That's because they feel horrible and they want to go try and stop the cravings. They equate it to feeling like they don't have oxygen. I've heard people say.
Really?
Yeah.
So, David, the professionals you described, the people who have, they're lawyers, whatever, how are they getting the opioids? Because with Epic and MyChart, we can't doctor shop.
People still doctor shop, and they tend to find their supplier. People will buy them off the street if they can't get the prescription. So people will find a way.
What's nice is we have something called MAPS that we use in the emergency department and you guys have access to it too, yeah. So MAPS is, I forget what it stands for, but it's a Michigan pharmacy tracking system. So I can see what somebody's been prescribed in terms of opioids or other addictive substances like Xanax or whatever. And so if somebody comes in and their story kind of sounds goofy, we'll check, and then that's an opportunity to say, hey, this is very risky behavior, what you're doing.
But it doesn't check Ohio. It doesn't check Indiana.
Yeah.
It doesn't check Illinois.
Yeah.
And they're all close enough.
And West Virginia seems like that's the epicenter of the problem in the country.
I mean, Michigan is really bad too.
Really?
Yeah, Michigan,
Everywhere.
especially along I-94 was really bad. Where in anything in like the Rust Belt, like it's the same like opioid belt.
Wow. Was it difficult to find street drugs?
No,
No.
not really. And once you develop, and Dr. Coldy touched on it, so it kind of controls your life. There's this physical dependency that it doesn't matter what your status is, if you're a lawyer or anybody. Like once you're physically addicted to it, you do anything to get it. So if that means going on the streets and buying what will make you feel normal, right? I'm a mother of 5, so that held me in my addiction longer. When I say that because I couldn't take time off for 5 days to come off of these opiates that I was physically dependent on.
Wow.
So without the use of medical assisted treatment, I don't think I would be in recovery today, because it allowed me to get the medication I need until I could repair things in my life.
So is this a new treatment method then for people who have what Brooke's been through?
The medication's been around, buprenorphine's been around for a long time, I think 20 or 30 years, but we're just now coming to a place where people like myself and David can prescribe it confidently and have a network that we can draw people into. And so we take those opportunities where somebody has had an experience like Brooke has, and they've perhaps used drugs they bought off the street. It was adulterated with fentanyl, right? And so then they didn't expect it to be as powerful. They stopped breathing. We see people, I mean, they're in tears when they come to us. They're exhausted, they're sad, they're ashamed, and when we talk to them, we just say, hey, we have this treatment. This is a non-judgmental space. It's not a moral failing. It is a medical problem, and we can help. And so we started a program at Henry Ford Allegiance ER where if somebody comes in, whether they're struggling with addiction or they've come in with an overdose, we can hook them up either with a primary care doctor like Dr. Coldy or a handful of other providers in our community or at the Center for Family Health. We can hook them up with an outpatient follow-up, or if they're in withdrawal, we can start the medication in the ED.
So is this a new tool then for you as a recovery coach, and then for everyone in the healthcare system?
So the new program that they're talking about, they opened in the hospital. I've been doing recovery coach working for Home and New Vision for 3 years now. There's been a lot of barriers when it came to getting people transitioned from opioids to a Suboxone treatment or other MAT treatments. So this is kind of bridging those gaps. So that's what I've been learning since I've heard more about what's going on, and that prescribers are easier to find, because a lot of people won't make that transition until it's easier, right? And now it's becoming easier. So that's nice to see for the people that I serve and I work with.
There were big barriers before. In order to prescribe Suboxone, you had to take an 8-hour class, but I didn't need to take an 8-hour class to prescribe as much morphine as I wanted. So it seems silly, but the DEA just lifted that requirement, and so we've been doing classes at Henry Ford through our department meeting, outreach in the community, educating people, and we have protocols that we can follow. And it should be said that this medication is, I think, and a lot of people say, superior to methadone, because methadone doesn't have the same ceiling effects. It doesn't protect you as much from overdose. It doesn't get people that sense of euphoria that you can sometimes experience with methadone. It just satisfies the receptors, stops the cravings. You can take it at home. You can manage it with your primary care doctor. You don't have to go to a clinic every morning. A lot of people who have busy lives would likely much prefer that, I imagine.
Yeah. And do we know the success rate of this MAT?
Statistics, I don't have the number off the top of my head, but without MAT, we know that people don't do well.
Yeah.
The other piece that we are still trying to get, connected is the behavioral health part. And I think that's where, Brooke and what the work that they do is so important, because I can do the medical piece, that's easy. But it's the behaviors. It's the, how do you avoid the temptations and, kind of change some things about your situation. And that's where I think really, this is the powerful piece right here that I think is missing.
The hardest piece too, for sure. I totally agree. You know, when we see people who come in with depression or anxiety, I often say there's 5 main pillars. You know, you got to have purpose in life. You got to have you know, exercise, treat your body well. You got to have family or friend support, counseling, and then medications. You know, if you just do medications, you're missing all the 4 parts of that equation. And there's not very many things that a pill will just fix. I mean, aspirin's great, high cholesterol meds are great, but if you're still eating, you know, cheeseburgers every day, good luck. You know, like.
Well, it's good to hear that we have a team of people and the health system and the support groups all paying attention to this. Thanks for coming in today.
Yeah,
Thanks.
Thank you for having us.
You bet. From Henry Ford Jackson Hospital, Dr. Alan Lazara, Emergency Services Physician, Medical Director for Primary Care with Henry Ford Health, Dr. David Coldy, and from Home of New Vision, Peer Coordinator and Recovery Coach, Brooke Cross. Thanks so much. More of the show after this. Stay tuned.